Today's objectives really are twofold. One is to talk about the pharmaceutical supply chain, and the second is the roles and responsibilities of market access. Professor Jamil is going to go over the U.S. market access, but we have two speakers today who are really going to go over market access outside the United States and real-world evidence. And I will introduce them later, but it's Dr. Ing Ho and her colleague Ashley Joska. So with that, I'm not going to be looking at comments right now. I'm just going to try and get through this. Again, feel free to ask questions. But all right, so the big thing to understand in the United States is how health insurance is provided. Many other countries, the government is the provider. In the United States, it's a mixture. It's a mixture of private and public. And on the private side, employers are the mainstay, almost 50% of coverage for us. Medicare is traditionally for older people, over 65, which actually isn't so old anymore, but it's over 65. And Medicaid is for people under a certain income level. So Medicare, Medicaid, about 35%. And the uninsured, these are people who have no coverage and may show up in an emergency room and to be seen, or may not get care, have a lot less access to care. Direct is people who buy insurance policies as individuals. The insured rate in the United States actually has fallen since we enacted the Affordable Care Act about 6 years ago. And much of that has gone into either the Medicaid bucket or some of the direct. So now for us, and when we talk about drugs, so who pays for the prescription drugs? Again, it's about, you know, for the 56%, 60% private, 40% public. And that's important because that means that we are seeing the cost, right? We are, especially in the individual bucket, when you're paying out of pocket yourself, that's a big deal. And also for the private insurers. And one of the reasons that so much attention has come on retail drugs at this point is because as a benefit, right, it's one of the benefits that individuals use a lot. So especially with employers, even though drugs, overall retail drugs, as we saw in the beginning classes, maybe 10%, 12% of the overall spend, for employers and employees, it's at 21%. So they really utilize that benefit and they see it. So the role of commercial payers. They provide, you know, all sorts of benefits: medical, dental, pharmacy, vision, pharmaceuticals. You know, there are many different types of plans. As you can see, these are some of the big names. They evolved to create networks of providers. So, you know, when you pick a doctor, you go to that, you know, it might be in network, it might be in a different network. There are narrow networks where you only get to see certain providers. There are other networks. So, you know, they create the networks, they process claims, they work with employers to determine what your benefits are. So not every individual has the same access to services. That 49% of employers work very closely with the payers to determine what they're going to cover for their employees. And payers have evolved over time. They're doing a lot more in terms of data and analytics. They are definitely a partner in terms of cost containment, controlling costs, and something called disease management, which really now has evolved into like chronic care management. It's helping individuals who've got chronic diseases manage that better. So like congestive heart failure, or obesity or diabetes. They help their employers and ultimately the people who are on their plan with those types of programs to help them stay better. So this is important to understand, and this has evolved over the past 50 years or so. A PPO is called a preferred provider organization, and an HMO is a health maintenance organization. PPOs really were what's known as fee-for-service, right? You pick any doctor you want to go to, you go see that doctor. Historically, you would pay a percentage and the insurance company would pay the other. Sometimes it was the insurance company would pay 80%, you pay 20%. And, it was no referrals, you just go, pretty easy to use. What happened is that, in a fee-for-service environment, the more you do, the more you make. So the incentive there is for providers to potentially do more or provide more services than may be necessary. Now, they might be necessary, but that, we saw increased utilization of services. And so employers started to see that, their premiums started to go up. And so these narrow networks were enacted, called an HMO, a health maintenance organization. These are fixed, smaller networks, so more controllable. Usually it's a co-payment, so a fixed fee that the patient pays. And the fee schedule, this is another term, the fee schedule that the HMO negotiates with the provider may be a lower rate, but it's the idea that they're going to get more volume. So there's also something called capitation, where a provider would get a certain amount of dollars. It's called per member per month. So, Bunny signs up with Dr. Ho. She's going to be my primary care provider. Whether I see her or not, the HMO is going to pay her a fixed fee per member per month. And the idea is she's going to keep me healthy, right? Because she doesn't want to see me that much. She doesn't want me to get sick because some of it is going to be, she's taking a little bit of risk on me. So that's the HMO model. The other thing to understand about the United States is there are a lot of variations on this. And so employers have a lot of latitude. The government has a lot, as we'll see in a second. But for pharmacy and others, it's important to understand this notion of a carve out. So historically, payers were very good and are very good at creating networks of physicians and processing those particular claims. They weren't, and those were actually the most expensive parts of the ecosystem. So dental, it was a nuisance. It was 5% of the spend. Vision, it was a nuisance. Mental health, they thought of somewhat as a nuisance too. So what they would do is carve these out. They would say, all right, we're going to contract with another organization to provide the dental network and all the dental. Same thing with vision, same thing with mental health. And for us, the most important one is prescription drugs. So prescription drugs were, historically, a while back, were not a big part of the spend, and they were coded differently. And so they were a nuisance. So payers offloaded them. And that's kind of how the genesis of what we call the pharmacy benefit manager has evolved, because it's a carve out. So we've talked about private payers, now the public. Medicare is the largest public payer. Historically, it's it's called Part A, Part B, Part D. So this isn't like that important, but I mean, it is important, but we just want to give you sort of a flavor of how complex the US healthcare coverage system is. So Part A traditionally paid for inpatient care, nursing homes, and those types of things. Part B were physician visits or outpatient care. Now, it's not free. Still, people over 65 will often pay an additional fee to get another, like a separate policy that reimburses things that Medicare doesn't cover. So Medicare doesn't cover everything. They also have a very specific fee schedule. So Medicare rates, you'll often hear providers say, are way too low. They don't cover any of the cost of what I deliver. And so, but Medicare has these fee schedules that correspond to certain services that are provided. About 12 years ago, and pharmacy had never been provided until 2006. So prescription drugs were never a benefit. In 2006, we had the Medicare Part D became part of the overall plan. And so outpatient prescription drugs started to be covered. Now, not all, but at least access to more than previously. Over the past decade or so, or more 5-6 years, we have something now called Medicare Part C, which is called Medicare Advantage. And this is probably the fastest growing part of Medicare. It's basically an HMO, a heightened HMO, in the sense that it covers a lot of the basics of A and B. It also will cover some Part D drugs, but you'll get additional benefits. You may get vision, which you didn't. You may get dental. You may get other things. And then on the other side, the provider may get some benefits as well if they're willing to take risk. The thing about, the old time A and B was, it was a fee-for-service type of environment, whereas Medicare Advantage is more of a capitated environment. So actually, let me stop. Are there any big questions that I need to? Nope, I guess not. All right. All right, now all of this brings us to the part you're most excited about, which is the pharmaceutical supply chain. So this is how it works. And it's very, like, when I look at this, I think, wow, this is really complex. And it is complex. And that's the whole issue, that it's complex, it's confusing, it's often quite opaque. And so many people have tried to make this diagram much more simple, but it's not. So the way it works is the manufacturer, big company, like a Pfizer or Merck, or any manufacturer, typically will contract with a drug wholesaler, to take possession of the drug. The drug wholesaler delivers it to the outpatient, like the pharmacy, might be a nursing home, it might be an infusion center, but that's how that goes. So that's pretty standard. And then the patient either picks it up at the pharmacy or the patient gets it in an environment. What's less straightforward is where this pharmacy benefit manager comes in and the payer. So that's what we are going to talk about. First, though, the wholesaler. So the wholesaler, you should know, three firms control 90% of the market, and you will see their trucks all over the place. In fact, right now they're one industry that's actually very busy, given everything that's going on with COVID-19. But they will purchase the drugs from the manufacturer. It's called wholesale acquisition cost. They provide safety and storage. They provide a lot of tracking. They provide the distribution mechanism, which, you know, the pharmaceutical company, that's not their expertise. This is their expertise. And, you know, they're basically logistics experts. But they have great visibility to where the drugs are at any one time in the chain. So in terms of logistics and like what's going on now, they really can be very helpful in terms of identifying how things move around. Pharmacies, you've all been to one. And that's really, you know, how most of us interact with the drug industry, right? When we go to the pharmacy to get a prescription, or now more so, you know, you've seen capsule, you've seen some of the newer entrants, Amazon, for example, so you can get it delivered. But the pharmacy is where we get our drugs. It can be retail and specialty. And they contract, as we said, for the wholesalers for the products. And they also contract with PBMs, which we'll get to. So just so you have a lay of the land, these are the top pharmacies in the United States. And what you'll notice is a lot of the same names and logos across retail, mail order, and specialties. So you can see CVS is in, you know, in all three categories. You can see that Walgreens is in retail and specialty and alliance. Under the mail order, Express Scripts, which is owned by Cigna. And actually Express Scripts is our PB, oh no, that's not true. Optum is our PBM at Columbia. And Optum owns Diplomat, Walgreens owns Prime. So basically, you know, whereas it used to be much more dispersed, there's a lot more integration now. So the big question is, why do PBMs exist? So as I alluded to before, it was somewhat an artifact of history that payers found drugs a nuisance a while back. And so they outsourced a lot of the claims management really to these PBMs. But over time, the PBMs got smart, just like the payers got a lot smarter and figured, we can do a lot more than just process claims. We can create networks of pharmacies for distribution and aggregation. We can provide mail order services for our clients so that they get their generic drugs much more easily. We can create formularies to help our clients, the payer usually, or the employer, maybe that's a way to help them manage costs. If we create, you know, these are the drugs that we approve, these are the drugs that may be more expensive. They also started a lot of programs, disease management programs, which, you know, payers do as well, but a lot of PBMs do that. The biggest benefit, though, that PBMs have come to serve over time is that they negotiate the lowest price, or they negotiate very hard with manufacturers in terms of pricing. And so that expertise is now concentrated. Really, 71% of the market is driven by 3 organizations. And when you think about who the organizations are, they're all part of payers now. So CVS is now part of, or Aetna and CVS are one. Express Scripts is part of Cigna. Optum Rx, which is our PBM, is part of United. So there's a lot of vertical integration that has gone on. And so you would ask, well, then why can't the payers take it over? Well, here's how the flow of funds kind of go, so you understand. So it's pretty straightforward that between the pharmacy, between the wholesaler and the drug manufacturer, that's pretty straightforward, and the pharmacy and the wholesaler. What's interesting here is the flow of funds between the PBM and others. So the PBM is paid, one, by the health plan to manage this pharmacy benefit. They're usually paid administrative fees. They're paid for the drug that they then pay the pharmacy for. They're paid dispensing fees, which makes sense. These are services they're providing. They then pay the pharmacy. They pay the pharmacy for the drugs that the pharmacy dispenses on behalf of the health plan. However, what sometimes happens is they pay the pharmacy less for the drug than they purchased it for at the health plan, which means they get, it's called spread pricing. And so they keep, or they've been keeping some of that money. The other thing they do, which is less, which is more controversial, has become more controversial, is the relationship they have with the drug manufacturer. So the PBM negotiates hard for a drug price, but the manufacturer also wants that drug to be prescribed by doctors, wants that drug on the formulary, wants that drug in a good place. And so they've developed, it's called, that you can call it a rebate, you can call it a bonus, you can call it whatever you want, but people call it a rebate. So if the PBM, if at the pharmacy, the manufacturer sees that, drug A has been prescribed, a lot, or drug A is prescribed, then the drug manufacturer on the back end provides a rebate, a bonus, back to the PBM. Now the PBM can keep it, or they can share it. They can keep all of it, they can share all of it, or somewhere in between. And so this is an example of, is a very simple example, but it shows you how it might work. And I say might because one of the biggest issues that we've seen with PBMs is that there's very little transparency, very little information is shared between the manufacturers and with the ecosystem in terms of how much those payments are, what kind of terms they are, et cetera. And, I'd say over the past well, certainly over the past 3 to 4 years, it's become much more visible about how invisible the entire process is. But here's a simple example, right? This is a blood pressure medication. The wholesaler buys it from the manufacturer for $100. The manufacturer pays the wholesaler a fee for all of the work, the logistics, the distribution, the mechanism. The wholesaler then sells that drug to the pharmacy. So the pharmacy makes its money from a combination of the patient has a copay in this instance, and from the PBM. So the PBM is paying the pharmacy let's say $61. But the health plan gave the PBM $63. Now it could be that plus an administrative fee, or it could be that the PBM is has the spread. Then the other way that the PBM is paid is through the manufacturer. And here you see for this one drug, this one prescription, the PBM is getting $33.50 in a rebate. And what does the PBM do? All right, well, here the PBM does shares some of it, about 2/3 of it, with the health plan, and keeps the rest. So the debate has been, well, if you're getting that rebate on behalf of me, the payer, I should get I should get all of that rebate back. That will help me lower my premium costs to my employers. That will keep costs down for their employees in terms of their insurance premium. And then another argument is that $33.50 should go right to the patient. Shouldn't even go back to the health plan. It should really accrue right to the patient. I'm not here to say which is right or wrong. I'm trying to give you like sort of the lay of the land of how it works. And again, I can't stress enough, we don't know exactly how it all works because there is some lack of transparency. So what else do PBMs and employers and payers do to control these costs? One is today, there's, you'll hear it all the time, that people, we are paying a lot more in terms of cost sharing. So historically, an employer might have covered let's say 90% of a drug. Now they're shifting more of the cost back to the individual, back to the patient, which means the patient actually sees and feels that at the point of sale, right? Like you go, you're paying, you feel that. Another way is through these mechanisms, like it's called prior authorization, step edits, and closed formularies. And we'll get to that in a second. Prior authorization means you can't automatically go get a drug, or your doctor can't prescribe it automatically. The doctor has to go through, it's called like utilization review at a payer to get it approved. So there's a step involved. The doctor can't make that. Specialty drugs, we've talked about that for the past several classes and how expensive they are. And so there are ways now that PBMs and payers are looking to manage those costs, coming up with some creative payment mechanisms. You read an article about it for today's class in terms of value-based payments. You know, they sound great on paper. It's really, you know, paying for value and paying for outcomes. But as you saw in the report from PwC, it's not so easy in practice. And so that's still under development, really. And then, you know, making the physicians and patients aware of what the costs are and how they're going to pay for it is also part of the process, so they become more visible. All right, Isabel, you raised your hand. What's up?
Yeah, so I'm trying to understand how things are here in the U.S. I'm not American. I'm from Brazil, and with my very limited knowledge on how this works in Brazil, I'm guessing because usually we don't have copay there. The insurance company pays everything, but they usually don't. You don't have access to your healthcare plan to specialty and very expensive medication. This you get from the government. So I was wondering if you also have that in the healthcare plans here, or if very expensive specialty drugs are still, like the insurance plans are still going to cover some of it here in the U.S. or how this different from.
Yeah, great question. And thank you also for bringing up how your system works, because I love other people to do that. So yes, first of all, some of these specialty medications are covered by private plans. They're not from the government only. However, they're not automatically covered, right? So the employer or the let's just talk about employers for now. You know, when the employer is contracting with the payer, they may say, well, we're not going to cover this time around, or they may cover it. So it's not automatic, but yes, private payers do. And then the government typically will cover a lot of the new entrants as well. But they will also mandate some of, actually, Jamil, since you deal with this, the high cost drugs, are you there?
Yes, I mean,
yeah. So when Keytruda Keytruda is one of the, is a great drug, but when Keytruda was approved, did the government automatically put it on its formulary?
No, I mean, even in the US, I mean, there is a process that you need to follow with both Medicare, Medicaid, and also the process which you follow with individual payers, where you come up with dossier that you have to submit. And there is a review of the P&T committee, the Pharmaceutical and Therapeutic Committee, which then puts you in a different formulary. And it's a process which is very quick. I mean, there's no HTA assessment. So then it goes really fast compared to other countries.
And also in the United States, isn't it true that oncology drugs almost always get approved?
Yes, and remember, most oncology drugs are infusion. There are oral drugs too. So it comes from Part B as in boy, rather than Part D as in David, which is the one you get from the pharmacy.
Yeah, and so again, that's a distinction, right? Part B Medicare, which covers which covers certain services, covers specialty, versus Part D, which covers other retail prescriptions. So so did we answer your question? Good. All right, so formularies, yay. Formularies are something that they're used to, to help individuals make choices about the drugs they're going to take, and also prescribers about which drugs they're going to prescribe. And so a formulary is nothing more than a list, right? And at this point, most organizations, it used to be when I was younger, a long time ago, there were maybe 2 tiers, but today there are often 4 or more tiers. And so Tier 1 is the least expensive, and that's where, you drive people to the, it's like a ladder. You drive people to Tier 1, the generics. And typically, if there is a generic for a drug, then it's, it's pretty good. It's pretty much the same compound. It is the same compound. So it's, people take it. In fact, in New York, just so you know this, if you get a prescription here, if there is a generic available, the pharmacist is mandated to give you mandated to give you that, even if the provider wrote for the branded drug. So generics typically are the least copay. Then this is where the manufacturer and PBMs start really getting into it, which is the second tier. Are you a preferred brand name drug? The third is if you're not preferred. If there might be several drugs in a class, and like in depression, there may be 6 or 7 different drugs in that class. They each have different, they have some different attributes, but one might be preferred. You'll pay $30. And this is just an example, and one might not be on that preferred formulary, and you'll pay more. And then finally, the specialty drugs, just like you were talking about, Isabel, these are managed differently because they are much more expensive. And they're also typically given or infused or provided in a different location, right? You're not getting them typically at CVS. So as I said before, the use of 4 or more tiers has grown a lot. And so that is, you can see here that, 3 tiers is sort of the big one, but 4 tiers is growing. This is another way that PBMs and payers control costs. It's called step therapy. So you can wow everybody at a cocktail party or an online Zoom cocktail party and talk about step therapy, which is fail first. So you've got to try the lowest cost option before the next option. So let's say you have asthma or an allergy. You'll try an over-the-counter drug first, then you'll try the generic. The generic doesn't work, you go to the next level. So that's one of the mechanisms. And then, as we said before, individuals, we are all now paying more. So we may have these, in the United States over the past several years, something called high deductible health plans have been implemented, which means you pay out of pocket a lot more before you start getting a benefit. You pay a lower premium, right, monthly, but you have to pay more out of pocket. And so in that case, you begin to really see what the costs are. We had some hands, I don't know who they are, so let's see. Oops. Isabel, are you still, or do you lower? Nope. Okay. All right, well, who else raised their hand? All right.
Bonnie, I did.
Oh, what? Ram?
Yeah,
Okay.
I did. I have a question. So when you say these drugs are moved between tiers and so on, are they still having the same active compound? And if so, then at least it's fine that there's a price difference. If not, like even if a doctor prescribes a certain active component for a disease or something, are the patients getting a lower tier product that might not have the same compound?
Yeah, well, first of all, if they're two branded drugs, they're not going to be the exact same compound, right? So they're two different drugs. So it's quite possible that the lower tier one is not as effective. I mean, look, in all of medicine, right, different drugs interact with people differently. And so one drug may work really well with an individual, and that drug won't work with another person. So any doctor will tell you they do not like this idea that a pharmacy benefit manager or a payer can control what they prescribe, because they are the professionals, they know, or even a pharmacist actually knows better. So to your point, you may fail on that one and then go to the next one. Does that make sense? I mean, it doesn't make sense, but does that answer your question?
Yeah, I think most, but I had one quick follow on. So in this case, also if it's a covered drug versus a preferred drug, and if the doctors see that the patients are not paying the money to buy it because it's beyond their reach, they might start basically prescribing the preferred drug. So essentially it also sometimes changes behavior. Does that happen as well?
Say that if the patient can't afford it, which means the patient is not going to pick it up or take it, then what?
So the doctors then basically prescribe a preferred drug or something that would be covered under their plan.
Oh, yeah.
Changing.
Yeah, definitely. So here's the thing though, a lot of times, because doctors see so many patients every day, or they may not have the tools involved, they often don't know, I mean, right at their fingertips, they often don't know exactly what's on a patient's plan. So this is a big deal. They or their office has to call the plan, find out what is covered, what isn't covered, and then find out what the copay might be. So all of that is an added administrative burden. But yes, I mean, if a doctor sees that you can't afford it, and then there is an option that may not be better, that if there's another option, the doctor's going to do it. All right. So again, this is just, pharmacy deductibles are growing. And to your point, Ram, about not being able to afford it, right? If you can't pay for it, then you're not going to pick up your prescription. And there have been multiple news stories over the past couple of years about that. So finally, this is a little bit tongue in cheek, but this is the PBM's point of view. They're keeping medications affordable, accessible, and that's their role. The physician point of view, as we were just talking about, is quite different, and often the patient point of view, because there are a lot of hurdles that they have to go through to get a drug. Employers may have different views. I think as a society, we're kind of trying to figure out where the PBM is going to go.